Good afternoon, everybody. We're going to give it just a minute or so folks can sign on. Thanks, everybody, for joining us today. I know it's a little bit dicey out there, to say the least. Give it just a few more seconds to let people join us. All right, I'm not seeing that number move much more, and I know that we have, oh, well, I spoke too soon, but I know that we have a lot of great content to get through today, so I'd like to go ahead and get started. Again, thanks everyone for joining us today. I know the timing is not great. I hope everybody is staying safe out there. And wanted to share some good news. If you haven't already seen, we were able to obtain CLE credit for this in the next 2 webinars. You will receive that CLE credit through email tomorrow, and I will also share the course number at the end of this presentation. So with that, I would love to introduce Amber Christ, Managing Director of Health Advocacy, and Hannah Diamond, Policy Advocate, both with an incredible national organization, Justice and Aging, who luckily are both safe from Milton. They're both experts in dual eligibility, Medicaid and Medicare recipients, and they're here today to talk with us about healthcare plans designed for those individuals and how we can increase our advocacy in representing those individuals involved in D-SNPs. So with no further ado, I'd like to kick it off by turning it over to Amber and Hannah, and thank you both so much for doing this today.
Thanks, Katie, and thanks, Nicole, for having us here today, and really thinking about you all and that you're all safe and your families are safe as Milton comes. I think, so sorry, my nose got hidden behind my window. So we're going to be covering, as Katie said, the dual special needs plans today. So those special plans that are designed for Medicare and Medicaid dually eligible individuals. As Katie noted, I'm the Managing Director of Health Advocacy here at Justice and Aging, and I'm joined by my colleague, Hannah Diamond. And this presentation is really building on the Medicare Basics presentation we did last week, if you were here with us for that. And we're kind of digging into these special plans that impact people who are dually eligible. Just a little bit about Justice and Aging for those of you who might not know about us. We're a national organization. We're focused on eradicating senior poverty by increasing access to healthcare and economic security for older adults. And we particularly focus on older adults who have been marginalized and excluded from justice, including older adults of color, older women, LGBTQ+ older adults, those with limited English proficiency, and immigrants, and those with disabilities. You can sign up for our network here and get information, and our emails will be at the end of this presentation as well. And Justice and Aging, it really is focused on centering equity in all of our advocacy and addressing the enduring harms of discrimination in our policy advocacy. And so you will see that in all of our materials and our resources and how we approach our advocacy. So turning to today's learning objectives, I just want to start off by saying that, you know, we are an organization that has always focused on the issues impacting people who are dually eligible. So we know a lot about D-SNPs, but every state and how they're implementing D-SNPs looks different, even though, you know, these are federal Medicare plans, how they end up looking in states is very different. So while we hope to provide a lot of education here today, we also really want to learn from you about what you're seeing on the ground, any issues you're seeing, or anything else that we may not have covered today that you would want us to cover in the future, or if we get something wrong for that matter. But in terms of learning objectives, our goals today are to get a better understanding of D-SNPs. That is to both assist your clients in making decisions about whether they enroll or if they should disenroll, but also to navigate issues they might be having in those plans. So we're going to focus on learning the D-SNP basics, including the different types of categories of D-SNPs, because, you know, it couldn't just be a D-SNP. There's different categories and requirements along with them. Understanding what the D-SNP landscape looks like there in Florida, and just heads up, it's pretty complex. And then that includes looking at the demographics of people dually enrolled and all of the different plan offerings there. And then at the end of the presentation, we're going to focus on some FAQs that we have regularly gotten during our trainings on D-SNPs. So Hannah, turning to the next slide. To start off, we want to kind of come up a level and talk about who are people dually eligible. So first, it's really important to understand that there are two categories of dually eligible folks. What we call full duals or full benefit dual eligibles. These are individuals who have both Medicare coverage and full Medicaid coverage. So they're getting the full scope Medicaid and everything that comes along with Medicaid. On the other hand, we have partial duals, and these are people who are enrolled in Medicare, but on the Medicaid side, they're really only enrolled in a Medicare savings program. That's the QuemB program or the SlimB program. Those Medicare savings programs, which are actually Medicaid programs, despite the name Medicare being in them, that help pay for Medicare cost sharing, including premiums and out-of-pocket costs. So partial duals do not have access to the full range of Medicaid benefits. They're only getting financial assistance through the Medicare savings programs. So turning to what that looks like in Florida, there are almost 1 million Florida residents, 957,000 as of 2023, who are enrolled in both Medicare and Medicaid. Of that total number, 493,000, or about 52%, are full benefit dual eligible. So those full duals, so have Medicare coverage and full Medicaid coverage. And then about 48% are people who are only enrolled in Medicaid to receive that financial assistance with their Medicare out-of-pocket costs. About 610,000 of those dually eligible people, or 64%, are enrolled in a D-SNP. So you have really high D-SNP enrollment in the state of Florida. Next slide, Hannah. You can see here a slide of where D-SNP enrollment is in the state. And of course, it varies pretty considerably from county to county, with some counties having a very high penetration, which are the red states, and then other counties having no D-SNP enrollment whatsoever, or really low D-SNP enrollment. And this is based on the resource from the Kaiser Family Foundation data. So it's based on 2021 data. I imagine it looks pretty similar today. You might see more red or more higher enrollment if we were to have the map today. In terms of demographics of the people who are dually eligible in the state, 75% of dually enrolled Florida residents are 65 and over. Racially, very diverse. 47% are white, 17% Black, 32% Hispanic or Latino, and then 2% Asian, and less than 1% of other groups. Gender, 59% female, 41% male, and then again, really diverse language. 27 reported having limited English proficiency, and the most common languages spoken other than English in Florida are Spanish, Haitian, and Vietnamese. So now turning to, now that we've established who are duals, what are D-SNPs and why do we need to be paying attention to them? So the growth of D-SNPs has been enormous, not just in Florida, but across the country. There are approximately 5 million dually enrolled or dually eligible people enrolled in D-SNPs in 45 states and Washington, D.C. And there are, as of the date of this data, there were 851 different D-SNPs operating across the country. 93% of duals live in a county where at least one D-SNP is available. So super high penetration across the country. And then since 2020, D-SNP enrollment has grown by 80% in Florida. So we've seen rapid growth of D-SNPs, both in terms of number of plans, but also in terms of enrollment. And thinking about who's enrolled in these plans in terms of demographics in particular, regarding their health, they're more likely to have a chronic illness, more likely to be admitted to the hospital, and more likely to be a person of color. Next slide, Hannah. So what are these D-SNPs? Like I noted at the top of the presentation, D-SNPs are a special type of Medicare Advantage plan. So Medicare Advantage plans are housed under, there's Medicare Part A, Part B, and then Part C is the private option, where people, if they want to, can elect to enroll in a private health plan that is responsible for delivering their Medicare benefits. And these are called Medicare Advantage plans or Part C plans. My mom likes to call them Medicare replacement plans. So lots of names, but they're the Part C plans. And then of those plans, the D-SNPs are a subset. Like all Medicare Advantage plans, D-SNPs have provider networks and prior authorization requirements. And then there are core elements that are unique to D-SNPs. Enrollment is limited, obviously, to dually eligible individuals or even a subset of the dually enrolled population. There in Florida, it's both full benefit dual eligibles and partial dual eligibles. Also unique to the D-SNP is the state Medicaid agency contract, or the SMAC. This is an incredibly important document that we're going to talk more about, but this is a contract that D-SNPs have to enter into with the state Medicaid agency that dictates the requirements and additional requirements for D-SNPs. And then there are federal requirements specific to D-SNPs that require at least some extent of care coordination with Medicaid services. To take a look at how this looks sort of in a visual way, you have sort of the umbrella of Medicare Advantage. And so then you have Medicare Advantage with prescription drug plans, you've got special needs plans, you have the program for all-inclusive care for the elderly plans, or PACE, and then Medicare Medicaid plans, which are actually being phased out in the states that they're currently available. Florida was not one of those. So if we look at SNPs, there are categories of special needs plans. So on the far right, we have chronic care SNPs, and then we have I-SNPs, which are institutional special needs plans that are for people in nursing facility settings or other institutional type settings. And then we have D-SNPs, dual special needs plans. And then of course, like I said, D-SNPs couldn't just operate as just D-SNPs. There are categories of D-SNPs. So we have coordination only D-SNPs, the co-D-SNPs, the highly D-SNPs, highly integrated D-SNPs, and FIDE D-SNPs, fully integrated SNPs. And Hannah will be going through these categories in more detail soon. But this kind of gives you a visual of the Medicare Advantage umbrella. Next slide, Hannah. So the benefits of D-SNPs include, and this is required, that all D-SNPs must offer the Part A benefit, the hospital benefit, Part B, the outpatient benefit, and Part D, the prescription drug benefit. So D-SNPs have to offer all of the benefits under A, B, and D that you would get under original Medicare. The D-SNPs also have the option to offer supplemental benefits, so things like dental, vision, and hearing, but also other types of supplemental benefits that we'll talk about in a little bit more detail later on. And then, of course, they have to offer that coordination with the Medicaid benefits, so that Medicare is coordinating with Medicaid. And then who regulates these D-SNPs? So it's joint oversight, really. It's the Centers for Medicare and Medicaid Services at the federal level that set minimum ground rules that are set out both in statute and then in regulations, and then CMS provides that oversight. And then states can use the state Medicaid agency contract to impose additional requirements on D-SNPs that CMS reviews. So it is also reviewed by CMS, but it's really the state that really does the oversight there. And those SMACs, like I said, are really important documents because they can set out like what enrollment is going to look like in the state, what level of care coordination is going to be put in place, what will plan materials look like. So there's a lot of things that get put in the SMAC, and a really important document that advocates should be aware of and push to both see and be a part of in the stakeholder process to get criteria in there that matters to consumers, to dually enrolled individuals. All right, next slide, Hannah. If we look at the D-SNPs and what it means to integrate care, first, what is integration, especially for dually enrolled individuals? And that's really the effective coordination of Medicare and Medicaid services. Medicare and Medicaid are two separate programs. They have different program rules. and coverage criteria. They have, Medicaid provides things for free. Medicare has a lot of payment stuff. So we see a lot of problems because the two programs are different and they were never really intended to work together. So these plans are supposed to be trying to integrate and coordinate those benefits. So for the enrollee, it doesn't seem like they're in two separate programs. Now, to the extent that those plans are doing that is another question, but that is the goal of integrated care. And it really is to streamline these complex systems and just make everything easier to navigate for the enrollees and those who are helping enrollees, their caregivers and their families. Next slide, Hannah. If we turn to who can enroll in these plans, first of all, the question is, are people, well, did I miss a slide? Oh, there we go. Yeah, I was like, wait a second. So generally, enrollment's limited to people who are dually eligible for Medicare and Medicaid. And that can include partial duals. And in Florida, you all have a lot of D-SNPs that are targeted just at partial duals. So partial duals, it's a little different, right? Because what is the D-SNP really coordinating? Because they're not getting Medicaid benefits. For the full duals, the D-SNP should be coordinating home and community-based services and their dental and vision, if that might be, and transportation covered under Medicaid. But when you don't have any of those benefits because you're not actually eligible for full scope Medicaid, what is the D-SNP coordinating? Not really anything. So we're somewhat skeptical about how well these D-SNPs are serving partial duals. I will note, though, that there is some documented evidence that these D-SNPs are helpful for partial duals because they offer some supplemental benefits that are more targeted at low-income people, even if they might not be low income enough to qualify for full scope Medicaid. So we do think that there's some benefit there. Next slide. A question we get all the time is, are dually eligible individuals required to enroll in a D-SNP? And the answer is absolutely no. Freedom of choice is a fundamental tenet and foundation of the Medicare program. So people always have the option to receive their Medicare and original Medicare. They can also choose other types of Medicare Advantage plans and the program for all-inclusive care if it's available. States can choose to automatically enroll duals into these plans through mechanisms like default enrollment. Like say you're in Medicaid and you're in Medicaid managed care, and then you become eligible for Medicare, you turn 65. They can default enroll you into the D-SNP associated with that Medicaid plan in some circumstances. But people always have the option to opt out of that default enrollment or automatic enrollment. There is no lock-in into any kind of Medicare Advantage plan in the same way that we see on the Medicaid side, where people have no choice but to be in Medicaid managed care. People always have a choice to be enrolled in Medicare managed care. Next slide, Hannah. So turning to those enrollment periods. So we're currently, well, let me start with the Medicare Advantage open enrollment period. That runs each year from January 1st to March 31st, where people can make changes to their Medicare Advantage enrollment. But every year during the annual election period, which we're entering into very soon, from October 15th to December 7th, is an opportunity for people to make any kind of change. So they can go from Medicare Advantage to fee-for-service Medicare. They can change if they're already in original Medicare. They can change their Medicare Part D plan. All kinds of changes can happen during fall open enrollment. People also have the opportunity to make changes during dually eligible people currently have the opportunity to make changes during the quarterly special enrollment period. This is a special enrollment period just for duals that currently exists, but is about to go away, where people can enroll or disenroll from their D-SNP and make changes to their Medicare Advantage plan once per quarter. And then that, like I said, that's going away in 2025, and I'll talk about that. There are also other special enrollment periods available to people regardless of dual status, just generally in Medicare. For example, if you move out of the area and you need to make a change, there's a special enrollment period. If you're leaving incarceration and coming back into Medicare, there's a special enrollment period. If you're go into a nursing facility or leave a nursing facility, there's a special enrollment period to change your Medicare enrollment. So all of those are listed at medicare.gov. Turning to the changes in the special enrollment periods for dually eligible people, there are two changes. So Hannah, if you go to the next slide, the quarterly special enrollment period that previously allowed dually eligible people and people with the low income subsidy or extra help is going away, and it's being replaced with, and that quarterly enrollment period allowed people to disenroll or to join a different type of Medicare Advantage plan. So that's going away, and it's being replaced by a monthly special enrollment period, in which people who are in a Medicare Advantage plan, if they're dually eligible or have the low income subsidy, can disenroll from that plan and return to original Medicare and a standalone prescription drug plan. And they can do that on a monthly basis. So it allows people to return to original Medicare with a standalone prescription drug plan. It does not allow them to enroll in another Medicare Advantage plan. So it's only to return, this monthly special enrollment plan period is only to return to original Medicare. Next slide. In addition to that monthly disenrollment kind of change that people can make, there's a new monthly integrated SEP, and this allows dually eligible people to make a change from, like, let's say they're not in an integrated D-SNP, they're in another kind of Medicare Advantage plan, or let's say they're in original Medicare, or they're in another integrated plan. They can make changes on a monthly basis too, but only if they're full benefit dual eligibles, so no partial duals, or not those with a low income subsidy. They can make a change to go into an integrated D-SNP. And of course, we're going to talk a little bit more about what those integrated D-SNPs are in just a little bit. But the point here of these two changes was to allow people who Medicare Advantage isn't working well for to return to original Medicare on a monthly basis. And that can be really important to low income dually eligible people. And then it was to prevent what was happening in the D-SNP market, which is brokers were pretty much luring people from plan to plan on a quarterly basis, or even non-D-SNP brokers. So just standard Medicare Advantage plans were trying to get duals into their plans. So the goal of this integrated SEP is to really limit what types of Medicare Advantage plans people can go into outside of annual enrollment. So really this is to further the goals of integration and limit people getting lured into non-integrated plan offerings. All right, next slide, Hannah. All right, I'm turning it over to you.
Thanks so much, Amber. Okay, so now I'm going to go over the different types of categories that we have when it comes to D-SNPs, and we have 3 different types. But before we do that, it's really important for us to understand some terms that are used to describe the relationship between the D-SNP and the Medicaid Managed Care Plan. So something called aligned enrollment is where the Medicaid services are either provided directly through the D-SNP or through a Medicaid Managed Care Plan that is affiliated with the D-SNP. So they have the same parent company. In other words, there is a financial relationship between the D-SNP and the Medicaid Managed Care Plan. Exclusively aligned enrollment takes this one step further. This is where the state is limiting D-SNP enrollment to only full benefit duals, so individuals who have Medicare and then full Medicaid benefits, and they are receiving their services via aligned enrollment, so via D-SNP and a Medicaid Managed Care Plan that are affiliated with one another. Throughout the remainder of the presentation, there are going to be a lot of acronyms if we haven't already gone over some. So exclusively aligned enrollment is often referred to as EAE for short, in case you hear me referring it as that. There are some benefits associated with exclusively aligned enrollments. When you have a financial relationship between the D-SNP and the Medicaid Managed Care Plan, there is an incentive for these plans to provide timely access to high quality care and address some of the integration challenges that Amber talked about in the beginning, which is, these two programs were never designed to work together, Medicare and Medicaid. There are duplicative services that act as a barrier to access, and it is in the plan's best interest to prevent more costly expenditures like unnecessary hospitalizations and nursing facility placements. Also with EAE, it is possible to have more streamlined communications and materials, and from the member's perspective, really make these plans seem like one plan. So we're going to talk about that as we move through these slides. When you have unaligned enrollments, this is what's possible in a fee-for-service environment. So you do not have a D-SNP and the Medicaid plan that are affiliated with one another. But we see this all the time in the Medicare Advantage landscape. You'll see a D-SNP and a Medicaid managed care plan within a service area that are not affiliated with one another. And we're going to talk about some recent changes that were included within the Part C and D final rule that likely will affect kind of what's happening within a service area when it comes to aligned enrollment. So here is a visual of what aligned and unaligned enrollment looks like. And we're showing you a visual from ICRC, the Integrated Care Resource Center. If you are not already signed up for their materials, I highly suggest that you do so if you're interested in information related to people duly eligible. They produce a wealth of information. So on the left-hand side, we're showing you both aligned and unaligned enrollment. So if D-SNP Company A was administering the Medicare benefits, and then the Medicaid Managed Care Company A was administering the Medicaid benefits, that would be aligned enrollment. When you have D-SNP Company A administering the Medicare benefits, but Medicaid Managed Care Company B administering the Medicaid benefits, that is unaligned enrollment. Okay, so now we can talk about our D-SNP categories now that we understand a little bit more about the relationships between the D-SNP and the Medicaid Managed Care Plan. So here we're showing you just at a very high level what these three categories look like. The FI D-SNP, or the fully integrated D-SNP, is our most integrated offering. Our second most integrated offering is the highly integrated D-SNP, or high D-SNP. And then the least integrated offering is our coordination only, or co-D-SNPs. Now, this is what the national landscape looks like, and it's almost time to update this slide as we're approaching the end of the year. But you can see that nationally, the majority of D-SNPs in the country are coordination only D-SNPs. So the D-SNPs that are offering the lowest levels of integration. This is followed by the high D-SNPs. And then you can see that our most integrated offering, the FI D-SNPs, account for a relatively small percentage of the D-SNPs nationally. And again, as Amber talked about with that special enrollment period and some changes contained within the Part C and D rule, we're hopefully going to see more individuals moving into these more integrated plans. So what is a FI D-SNP? A FI D-SNP is covering all Medicare services and almost all Medicaid services. So right now, FI D-SNPs must cover Medicaid primary and acute care services and long-term services and supports, including at least 180 days of nursing facility coverage. Starting in 2025, these plans will also be required to cover additional services, including home health, Medicare cost sharing, behavioral health services, and medical equipment, supplies, and appliances. The other thing in 2025, these plans must operate with EAE, or exclusively aligned enrollment. So they are going to be limited to full benefit duals that receive their services via aligned enrollment. These plans, from the member perspective, have policies surrounding them that really attempt to make these plans look like one from the member's perspective. So they're offering the highest level of integration. There are robust or more robust care coordination requirements, which Amber's going to talk about. These plans have integrated enrollee communications and materials, including a single member card. There is an integrated appeals and grievance process, which we're going to highlight. I will note that these plans are not offering this higher level of integration out of the goodness of their hearts. They are paid a higher level of payment from Medicare. And it's important that you all as advocates know about the requirements surrounding FI D-SNP so that you can hold these plans accountable to deliver that higher level of integration. And as I mentioned, D-SNPs right now account for a relatively small percentage of the D-SNP landscape. But as I mentioned earlier, because of changes contained within the Part C and D rule, and also because we're seeing the MMPs or the Financial Alignment Initiative states that Amber mentioned transition and end, most of them are transitioning to D-SNPs. So we're going to see probably more D-SNPs in the future. What are high D-SNPs? Okay, high D-SNPs are one step down. These are D-SNPs that provide all Medicare benefits and some, almost most Medicaid benefits. But there are permitted carve-outs for high D-SNPs. So the permitted carve-outs here are either behavioral health or long-term services and supports. And different from D-SNPs, unlike D-SNPs were in 2025, they have to operate with exclusively aligned enrollments. These plans are not required to do so. The other thing that we encourage advocates to think about when it comes to D-SNPs is that these plans provide a really good platform to achieve a higher level of integration. So they are a stepping stone to achieving D-SNP status. And that's really important for you all to think about because you all have a lot of D-SNPs in Florida. And then coordination only D-SNPs. These are D-SNPs that are not HIDE and D-SNPs. These are D-SNPs that are offering the lowest level of integration. They are abiding by the very basic care coordination requirements, but they have no clinical or financial involvement on the Medicaid side. So they are not covering any Medicaid services. And their very basic care coordination requirement is that they have to notify the state when a particular entity of high-risk enrollees are hospitalized or admitted to a nursing facility. So here's what this looks like visually. Again, this is an ICRC graphic. So you can see all the way on the left-hand side, we're showing you traditional Medicare and then the Medicaid services, whether or not that's fee-for-service or managed care. They're all separate from one another. This column here, we're showing you Medicare Advantage and then the Medicaid services. So in Medicare Advantage, these plans are offering parts A and B and then likely D. So that's shown by all one blue box here. And then the Medicaid services remain separate. This third column here, this is where we start to see our first D-SNP, the coordination only D-SNP. So you have the parts A, B, and D being covered, they're all in one. And then you have your Medicaid services, which remain separate. Remember, the D-SNP is not covering any Medicaid services. But then you can see that there's these arrows here, and this is showing you the very basic care coordination requirements that those coordination only D-SNPs have to abide by. And then you can see in this column, this is where we get to our more integrated offering. So you can see that these D-SNPs are covering Medicaid services. So now you start to see all one color here denoted by green. And then we're also showing you here the care coordination requirements that these plans have to abide by and the integration requirements surrounding these plans. And that's demonstrated by the arrows. Okay, one more acronym just to add to our complicated landscape here, and hopefully this is the last one we're going to share with you today. There's something called AIPs, or Applicable Integrated Plans. This is a relatively new designation for D-SNPs. And this basically these are D-SNPs that are operating with exclusively aligned enrollment, so EAE, and they are covering Medicaid services. So a D-SNP, all D-SNPs by 2025, because they're required to operate with EAE, they will all be considered AIPs. High D-SNPs can be AIPs if they operate with exclusively aligned enrollment. Remember, they're not required to do so. And coordination only D-SNPs, they can be AIPs if they operate with exclusively aligned enrollments and they cover Medicaid primary and acute care services and one additional service, whether that be behavioral health, long-term services and supports, home health services, or medical supplies, equipment, and appliances. One thing that's really important to know about AIPs is that They must have a unified appeals and grievance process that takes into consideration both Medicare and Medicaid benefits. So the big picture takeaway here is even if you have a coordination only D-SNP that's abiding by the very, very basic care coordination requirements, you can improve the level of integration that is offered via those plans if they became an AIP. So just something for you all to think about when we show you your landscape, which here it is. You have a lot of D-SNPs in your state. You have 112 D-SNPs. 16 of those are coordination only D-SNPs, so the D-SNPs that are operating with the lowest level of integration. 91 of those are high D-SNPs. And of those 91, you have 8 that are operating as AIP. So they're operating with exclusively aligned enrollments, and they're going to be providing that integrated appeals and grievance process. And then 5 are FIDE SNPs offering the highest level of integration. Okay, so we wanted to alert you all to a change that was contained within the most recent Part C and D rule that likely is going to reduce the number of D-SNPs in Florida, with the hope of really simplifying the choice landscape. So starting in 2025, if a D-SNP and a Medicaid managed care plan are affiliated with one another and within the same service area and serving full benefit duals, there will be a requirement that there can only be one plan servicing that area with that affiliated relationship. So currently, Medicare Advantage organizations can offer more than one D-SNP within the same service area with very little difference between those plans. So the purpose of this is to simplify the choice landscape within a service area to provide meaningful choice to members. So in 2027, those plans will only be permitted to enroll new members via that affiliated, that aligned enrollment. And then by 2030, these plans have to have members who are only enrolled via affiliated or aligned enrollment. So again, just zooming out, the purpose of this change is to simplify the choice landscape and really provide members with meaningful choice. And with that, I'm going to transition it back to Amber to talk about D-SNP requirements.
Thanks, Hannah. So all D-SNPs have some minimum requirements set by federal law. They have to develop an evidence-based model of care. And this is really the way that plans operationalize the requirements in the state contracts. So they have to come up with this. They're often cited as being proprietary, so we don't really get to see these model of care, although the state Medicaid agency does. The public does not, but this is really where they're trying to operationalize those requirements and these care coordination requirements. They are supposed to coordinate all Medicaid benefits, including Medicaid fee-for-service benefits. So if there are carved out benefits from Medicaid managed care, the D-SNPs are supposed to be coordinating those in addition to the Medicaid managed care benefits. They are supposed to assist with grievances and appeals. And as Hannah noted previously, there's requirements about integrated grievances and appeals, but no matter what, D-SNPs are supposed to be assisting people with grievances and appeals. They are required to screen people for transportation, housing, and food needs to make sure that they are screened for those and then being connected to those services. And then as of January 2025, all D-SNPs must establish an enrollee advisory committee. Next slide, Hannah. With regard to care coordination, again, there are minimum requirements for all D-SNPs. They have to coordinate Medicare services across the delivery spectrum from, Part A hospital to Part B and their prescription drug plans. They must establish a care plan and a care team. They're supposed to ensure communication among providers. A lot of times providers are not talking to each other and operate in somewhat of a silo, which is not how we all are as people. We're not siloed. So they're supposed to help with that. And then there are specific requirements about coordinating during transitions. These are times in people's lives that a lot of disruption happens and people end up in not so great circumstances. So they're supposed to help during these transitions from hospital to skilled nursing to home. I will just note that we so often hear that people who go into a hospital setting, for example, won't hear anything from their Medicare Advantage plan, even though the care coordinator should be helping think about how are we going to transition them to home with the right supports. So if people aren't hearing from them affirmatively, they should be reaching, like their Medicare plan should be helping with that. Their D-SNP should be helping with that. And then they're supposed to be assisting with maintaining Medicaid eligibility. And of course, that was really important during the public health emergency unwinding. These D-SNPs were supposed to be helping their members maintain their Medicaid eligibility during that process. I, for one, am skeptical that that happened since we saw so many administrative terminations, to what extent the D-SNPs were actually doing this. Next slide. In addition to the minimum care coordination, coordination-only D-SNPs are required to notify the state when a member of a high-risk group is institutionalized or hospitalized. Each state gets to dictate who's high risk, what high-risk group is, and how that notification is supposed to be operationalized, but that is an additional requirement of coordination-only D-SNPs. And then, of course, D-SNPs with the highest level of integration and requirements have additional requirements. They're supposed to be using aligned care management and specialty care networks for high-risk enrollees, and using state-approved strategies to coordinate or integrate member materials, including all communications, grievances, appeals, and quality improvement. Really, to the member, a D-SNP should look like one plan. That is the goal of the D-SNP, is that people shouldn't know that they're in two different programs at all, is the whole point of a D-SNP. Next slide, Anna. In addition, on the D-SNPs all have requirements around social determinants of health, which are, those conditions and environments where people are born and live and work and play. The D-SNPs are required to learn about an individual's situation through a health risk assessment. So every D-SNP has to do a health risk assessment. And then they're supposed to address any social drivers of health or social determinants of health through their supplemental benefit offerings. They're supposed to have in place processes to refer people to other assistance. So like maybe someone doesn't have SNAP and they should be on SNAP, or they need LIHEAP for energy assistance. They're supposed to be making sure that there are protocols in place within the plan to refer people to get that type of assistance. And they're really supposed to be collaborating and partnering with community-based organizations to make sure that they're addressing those social determinants of health. Plans also have the option to offer these supplemental benefits that go beyond the original benefits in Medicare Part A and Part B. And these can be very broad, from vision, dental, and hearing to now we are hearing increasingly about food assistance, our cash cards to purchase food or other types of items. So plans can offer these things. We could get into another discussion about whether they should be, but they do are at this point permitted to offer those types of benefits. We think it's really important that if D-SNPs are going to be offering supplemental benefits, that they shouldn't just be a marketing ploy to attract new members, but actually should be supplementing what people have under original Medicare and under Medicaid. They should not supplant or make it more difficult to access Medicaid benefits, which oftentimes we see is that these supplemental benefits act as an impediment to gaining access to benefits that people already had under Medicaid. We've noted a number of changes coming under the Part C and D rule at different times. A lot of these changes are going into effect, have already gone into effect, or will go into effect in January 2025 to kind of bring some more transparency around these supplemental benefits. While plans have been, quote, offering these supplemental benefits in increasing numbers, we don't know anything about the extent that they're being utilized, whether there's disparities in utilization. And so there's rules that went into place in October to curb misleading marketing around these benefits, because sometimes the supplemental benefits have criteria about who's eligible for them. So some marketing restrictions there, like you don't have, some celebrity on TV saying that everybody has access to these benefits when in fact they don't have access to these benefits. Or they'll say that the plan is paying for Medicare cost sharing, but that's really the Medicare savings program. And the person was going to have that anyway. And then the Medicare plan is advertising that they're paying for it when in fact they're not. So that type of misleading advertising has been cracked down on. There's some rules to stabilize the eligibility criteria for some of these supplemental benefits. SSBCI are the supplemental benefits for chronically ill benefits. So they're for very specific subpopulations. The plans are supposed to show evidence that these benefits are actually helping with people's well-being and healthcare. And then in order to make sure that people know that they have these benefits and that if they haven't used them yet, there's mid-year notices that the plans are supposed to send to people about what they've used and what they haven't used to ensure that people are actually using them and know that they have them. Turning to integrated appeals processes, as Hannah noted previously, D-SNPs with the AIP designation must offer a unified appeal process at the plan level. That means that they're sending a single notice and everything kind of gets integrated into the appeals process. Non-AIP appeals are not integrated. Of course, by D-SNPs, they're going to have to offer integrated appeals starting in January 2025, regardless of AIP designation. Well, they will all be AIPs in 2025, I should say, all by D-SNPs. All right. Well, turning now to frequently asked questions and giving it back to Hannah to kind of reemphasize some of the points we've covered so far.
Thanks so much, Amber. Okay, here we go. So a question we always receive, should a person who is dually eligible join a D-SNP? And the answer is, it's a very personal decision. As we talked about a few times, I think, the more integrated offerings, especially a D-SNP, they are really aimed at addressing the integration challenges between Medicare and Medicaid and some of the pain points that individuals experience as they're trying to navigate these two programs. And with these higher levels of integration, you get what can seem like one plan from the member perspective. You can get supplemental benefits that hopefully supplement and add on to Medicare and Medicaid benefits. And then you also get consumer protections that are available via these plans. At the same time, as we've noted, sometimes these plans are not delivering on the promise, on the regulatory requirements. And also, these plans function within a Medicare Advantage landscape. So these plans have a contracted provider network, so an individual has to see someone within that provider network. Individuals have to receive oftentimes a prior authorization before receiving a service. So it's really important that if a person is considering a D-SNP for their plan and they have a particular provider that's important to them, they have a particular prescription drug, they have a particular service that they must receive, that they are confirming that they can access their needed providers and benefits via the D-SNP. Okay, so I mentioned this in the last slide. Do D-SNP enrollees need prior authorization? For the most part, yes. There are a few exceptions. It does depend on the plan and the particular service, but yes, most services offered through D-SNPs require prior authorization. And you can look at the evidence of coverage documents for specifics regarding which services are subject to prior authorizations. As we noted, can an individual receive services from any provider? The answer for the most part is no. So these plans are operating within a Medicare Advantage landscape. D-SNPs contract with a provider network. So individuals can see a member within that provider network or a provider within a provider network or a provider who agrees to accept payment from the plan. If a potential enrollee has a provider that is very important to them, you can check with the D-SNPs provider directory to see if that provider is included, which is available on the plan's website, and there are print copies that are also available. But oftentimes the provider directory is out of date. So we would actually advise for you all to call the plan directly to see if that provider is within that plan's network. Okay, PPO D-SNPs. These are kind of an exception to the rule when it comes to the provider network. In theory, these are plans that give people dually eligible more flexibility in choosing their providers, as individuals can see not only providers that are within network, but also out-of-network providers. Florida does have PPO D-SNPs. We have heard from advocates concerns surrounding PPO D-SNPs, specifically around billing, improper billing when it comes to people dually eligible. So we would love to hear from you all if you have experience with PPO D-SNPs, good or bad. We would be interested in your feedback. And then, are there costs associated with D-SNPs? For the most part, no, there are no costs. Of course, there are a few exceptions. If a D-SNP is offering additional services, they can charge an additional premium, or if an individual is seeing a provider that is not within the provider network or receives a service that is a non-covered service. But for the most part, no, there should be no costs. And with that, we have a few resources that we'd like to share with you all. This is a slide with various documents that are important for advocates that are working alongside people dually eligible. Just flagging for you all these various documents and what you can use them for. As we mentioned, I'm just going to highlight the SMAC, the State Medicaid Agency Contract. This is a really important document where you can find out specifically how that D-SNP is providing care to people dually eligible, but also it's a great opportunity for advocates to inform the design and delivery of these plans. And then some more resources within the Justice and Aging resources that are listed on this slide, and you all will have access. I think Nicole is going to share them with you if she hasn't already. I just want to alert you to this sub-bullet here, our listserv registration. We at Justice and Aging have a Medicare and Medicaid integration workgroup listserv. This is a listserv of advocates across the country that are working on issues related to people dually eligible for Medicare and Medicaid. We share information through this listserv. Advocates share and uplift best practices. They ask questions. We also convene this group on a quarterly basis to provide information about changes, for example, changes that were contained in the most recent Part C and D rule, changes that are happening at the federal level when it comes to legislation or potential legislation. So if you are working in this issue area, I would encourage you to sign up for a listserv. I also want to alert you all to this new resource that we have. It's a Florida-specific fact sheet that contains the D-SNP landscape information and the demographic information of people dually eligible. The information that was kind of contained at the beginning of this presentation. So if you're looking for Florida-specific information about the plans themselves and about people dually eligible in the state, this is a great resource. And with that, our contact information is here, and we would welcome any questions.
Thank you guys so much. And yes, I was just going to say, please drop your questions in the Q&A or the chat. We're monitoring them. And while we're waiting to see if anybody has any questions, Amber and Hannah, I had a few too. What an incredible presentation. Given that Florida's Medicaid is predominantly administered through managed care, and we are coming up on a new procurement period starting in February of 2025. That's going to change, just to make everyone aware, it's going to change how people are automatically enrolled into Medicaid managed care. I'm wondering, where would we look for rules regarding automatic enrollment in D-SNPs? Would that be controlled by our Florida specific SMAC, or where else might we find it?
Actually, CMS, Katie, has the list of states that it's approved for that. We can send the most recent document that we have on that. I can't remember if Florida was one of the states, Hannah, but we can send that. Yeah, and that it'll be interesting too, Katie, to see how that impacts we're always constantly thinking about how the reprocurement on the Medicaid side that impacts the alignment that can happen on the D-SNP side. So it'll be like if you have new Medicaid managed care plans coming into the market, if some are exiting, that can really influence like what the D-SNP landscape looks like too. I will also note something that's kind of unique about Florida and your HIDE SNPs that we learned about is that I think this is how it works. Correct me if anybody actually knows, but your HIDEs are, there is no Medicaid managed care. They're providing all the Medicaid benefits that the Medicaid managed care plan would be providing. If someone has long-term care and then they're enrolled in a Medicaid managed care for long-term care, then that looks different because then they'll be in the Medicaid managed care plan for their long-term services and supports. But if they're not getting LTSS, then the HIDE SNP is providing all of the Medicaid benefits, which is fair, to my knowledge, one of the only states that I've seen that in, where the HIDE has taken over the Medicaid benefits rather than it being an associated Medicaid plan. Yeah.
Interesting. That's really well, and it actually raises, I'm going to make sure I'm not the one holding the floor here. It doesn't look like we have any questions in Q&A or chat as of yet. It makes me wonder, Amber, for the AIPs in the integrated appeals process, are we still going to see for Medicaid managed care services, including an LTSS, are we still going to see the provisions of 438, 42 CFR 438, which governs Medicaid managed care grievances and appeals at play, or are we looking specific? Okay.
Yeah, so this is I think this is one of the sticking points is that I think what was happening is that some of these HIDE SNPs weren't being governed by the Medicaid managed care plan rules, and CMS stepped in and said, no, you don't get to circumvent those just because you've come into the D-SNP. And I'm not sure how that's shaking out because it feels like it's all behind closed doors there in Florida. And so I'm interested to see what the HIDE SNP landscape actually looks like in 2025 and whether those HIDE SNPs will still be offering the full range of Medicaid benefits specifically for that reason, Katie, because I think that they weren't abiding by sort of the federal rules around Medicaid managed care in the way that they should have been. Yeah, Hannah, you were going to say something.
Yeah, the only other thing that I would add there is we did clarify that the HIDE SNPs in Florida they qualify as an integrated plan. So for the purposes of the special enrollment period on a monthly basis where individuals can make a change if they are a full benefit dual to an integrated offering, the HIDE SNPs are an option for them, including the HIDE SNPs and including a coordination only AIP. So that's something that we got a little bit more clarification on, again, because of the unique landscape in Florida, but HIDE SNPs as of right now will count. And as Amber mentioned, we anticipate some changes next year. So maybe if we came back and gave this training 6 months from now, we might have a different answer. But as of right now, that's our understanding.
And just for the sake of clarity, because not being steeped in this at all and knowing that most folks on this presentation are not, I just want to reemphasize. So for those individuals who are on Medicare and Medicaid through long-term care services and supports, the LTSS services are going to be administered directly through the Medicaid managed care plan, regardless of these shifts in landscape. Is that correct?
That's correct. Yeah.
Okay, that's very
except for the FIDE SNP is sort of the most integrated, so it's going to look more like a one plan option to the member, but technically it's still that Medicaid managed care plan offering the LTSS side of
okay. And in those FIDE SNPs, just to echo that. Thank you, Amber. I have one more question if folks have time. But first, actually, let me do this. So folks can jump off. Let me share the CLE information as we wind down to the 1 o'clock hour. Just give me a second to pull it up. That CLE information, the course number is going to be 2410885, N as in Nancy. And I'm going to ask Nicole LaRock to please drop that in the chat. Again, it's 2410885. 5, N as in Nancy. And the course title is Navigating, of course, Dual Eligible Special Needs Plans, or D-SNPs. So thank you all for joining us today. If you want to jump off, I'm just going to ask one more question related kind of to the PHE unwind. We saw a lot of individuals, of course, erroneously lose Medicaid eligibility. Some of those individuals were individuals who were duly eligible and lost their enrollment in the D-SNP as a result of the loss of Medicaid eligibility. In those instances, is there a good grievance process that someone should exercise to ensure re-enrollment after the state fixes the erroneous Medicaid termination?
There's not really a grievance procedure, Katie. And what as advocates, what you could be pushing for is a deeming period, which would allow people who lose eligibility for short periods retain eligibility for the D-SNP until they can reestablish Medicaid eligibility. And many times that's advantageous for the D-SNP because they don't want to lose that enrollment ultimately either. So we've seen deeming periods for 3 to 6 months. So I think that that's what you want to be as a systems fix, like that's what you want to see is longer deeming periods. And then you really do want to be pushing those D-SNPs to be helping maintain that Medicaid eligibility. Like it's ridiculous that anybody in a D-SNP really, for administrative reasons, lost their Medicaid eligibility. The D-SNP should have been helping with that. And in doing so, like partnering with an organization like you all or other legal services to help maintain that partnership can be so crucial. Yeah, Hannah, you came off.
Yeah, so just to add on to what Amber was saying, so that would be clarified within the SMAC. Again, this really important contract that we keep bringing up. And the deeming protections allow someone to stay within the D-SNP and then maintain their Medicare benefits while they're attempting to regain their Medicaid. In some circumstances too, depending on how strong you write that contract language, you can try to get the D-SNP to also cover those Medicaid services during that time. The plan may or may not want to do that. There's likely more pushback there. But again, as Amber was saying, it's advantageous for them to keep members within their plan. So we see other states using deeming protections. It should be something that advocates are pushing for. And also something just to look at in the future that we anticipate producing at Justice and Aging early next year, hopefully in advance of your procurement process. We're going to be producing a consumer-oriented, a beneficiary-oriented SMAC. So what are the provisions that are really important for you all as advocates to advocate for? So be on the lookout in early 2025 for a document like that contains integration elements that are really important in a SMAC and consumer protections like the deeming component that we're talking about now.
That is excellent. Thank you, guys. And I could really talk about this all day, but I want to make sure other people's questions get answered as well. And Lynn Monshine just dropped in the Q&A. To be clear, if a person is dual eligible but has a supplement, not Part C, can they enroll in a D-SNP?
No, and it's really, I think you mean by supplement a Medigap plan, and it's super rare for dually eligible people to have a Medigap plan because technically you can be kind of grandfathered in because of, well, how does this work? If you're Medicaid eligible, you're usually not eligible for a Medigap because Medicaid is your Medigap. Like it's your supplemental. But if you had, how is it? There's one exception, like if it goes one way, you can maintain that Medigap and also have Medicaid coverage. Oh, if you already had a Medigap and you become Medicaid eligible, you can retain your Medigap coverage. That's how it works. But no, because the D-SNP and the Medicaid plan should be covering everything. So there's not an instance where you would be in a Medigap plan and a Medicare Advantage plan. That goes across the board, not just duals. So anybody who has a Medigap plan cannot also be in a Medicare Advantage plan. The Medigap plan is acting as your supplement. I will just reemphasize there though, these enrollment decisions are really important because sometimes if you go into you choose a Medicare Advantage enrollment right when you're coming in, and let's say you have some sort of healthcare crisis and the Medicare Advantage plan is not good for you anymore, and you want to return to original Medicare, non-duals, talking about non-duals, your ability to get into a Medigap plan can be prohibited because your pre-existing condition can prevent you from going into that Medigap plan, or it might be too costly. So those decisions, especially at initial enrollment, can have really like long-standing implications. So just something to flag. Again, this is non-duals, but just an important intersection about Medicare Advantage and Medigap is those enrollment decisions have ramifications way down the road.
Which is a good plug for our state SHIP program, Shine, Florida Shine, which if folks are not familiar with, is a state-based Medicare navigators program out of the Department of Elder Affairs, and they have incredible advocates who can answer those kinds of enrollment questions. With that, I'm hoping for those folks who were able to stay on a little past the 1 o'clock hour, that you stay safe in the storm. We again are very grateful to Amber Christ and Hannah Diamond from Justice and Aging for joining us today and explaining these incredibly complex but incredibly important programs. And we hope to see you next Wednesday. Eric Carlson from Justice and Aging will be joining us to talk about nursing facility discharges. Everyone, again, stay safe and thank you for joining us.
Thank you.